The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, dealing with infections.
They're going to be interested in the cost, they're going to be interested in the penalties, they're going to be interested in the reputation, and they're going to be interested, hopefully, most of all, they're going to be interested in the individual patient and the patient experience.
That's Dr Peter Lowthian, a former Executive Director of Medical Services, currently serving on the boards of a large private hospital and the Australian Cardiac Surgery Research Institution. And I'm presenting him with a difficult scenario.
You have to make a coherent case for why this is a major priority.
In this episode, Peter will discuss what to do when your hospital develops a high infection rate. In this scenario, a new benchmark report is eagerly opened by hospital administrators, but it includes details of a high hospital-acquired infection rate when compared to peer hospitals. A review of the most recent internal quarterly infection report appears to show that there is a high rate of urinary tract infections, particularly in the orthopedic ward. I started by asking Peter what concerns a report like this raises.
It raises a number of concerns. The automatic reaction of clinicians often is to say the data's wrong, and that would be a major concern to me. Reports like this, though, are flags that you've got potentially a real problem. So the first step has to be, is the data correct? And so data integrity, how it's collected, what the definitions are you under-reporting, for example, or are you over-reporting? All of those issues need to be assessed. You also need to understand your own data. So once you've validated that, yes, you do have a problem, you've then got to say, well, where is the problem? Is it uniformly across orthopedics? Is it only in certain groups, only certain conditions? And then you've got to go looking and say, well, what are the longer other problems that we might have associated with the infections as well? So it really does open a whole governance and clinical scenario.
Let's tease out that area of, is the data valid? What are some of the challenges that arise in collecting and reporting clinical incident data?
The main challenge that arises is actually getting buy-in from the clinicians, and they have to be confident that it is being collected appropriately. So your definitions come into it. The definition of, is it coming from, say, coded data? Is it coming from the laboratory? Is it coming from ward-based collection data? How is it being collected? And it's reasonable to say that ideally the simplest, most accurate way, which has the least effect on people's work patterns, is the best way to collect data.
One of the issues that always arises was the infection present on admission, and so can the hospital be held accountable for that? How do you make sure that the infection rate that's being reported is actually arising during or from a hospital intervention?
The only way you can do that is to actually go and look at your systems, because if someone comes in, for example, for a hip replacement and they have asymptomatic bacteriuria, you're not going to know that if you actually don't look for it. So you need to know that your system of assessing the patient before they come in or at the time of entry to the hospital, unless you have a system that is actually identifying that, picking it up, whether it be testing in the ward or testing before they come in, the patient comes in, you're never going to know that it was just related to the hospital. It's also got a clinical importance as well, though, and that is that if you've got people who do have infected urine or bacteriuria even for that matter, then they're at risk of getting prosthetic and other infections associated with the conditions.
Certainly the consequence of infections can be quite catastrophic for patients. How can you be sure that you're really comparing apples with apples? Every hospital's different. I don't think there's one hospital in Australia that's perfectly similar to another hospital, but comparing a large acute teaching hospital with a day surgery hospital is rather unfair. How do you make sure that the agency that's reporting the data to you is actually comparing you with a similar hospital?
You need to have that discussion right at the start, so that you need to know that whoever's going to be doing your benchmarking has access to sufficient similar types of hospitals. And you'll only know that by actually saying, all right, how many hospitals over 300 beds do you have? How many private hospitals do you have? How many teaching hospitals do you have? Are you going to use the appropriate cohorts? Because it's not just day procedures. It could be a smaller hospital that only does short stay, 2 to 3 day orthopedic elective cases, as opposed to joint replacements, older age cohorts, people who are at higher risk of infection anyway.
It's easy to dismiss urinary tract infections, particularly I think in the Australian context, as, look, it's only a urinary tract infection, what are we worried about? How do you respond to management or even clinicians who suggest that urinary tract infections aren't worth the effort?
I think it comes in 2 ways. The first is you can go and look up the cost aspect of it, but most places actually don't have accurate ways of assessing that. But the conversation needs to be, firstly, urinary tract infections carry an individual patient burden. The patient experience is different. The risk of other infections, prosthetic infections, patients getting multi-resistant organisms, patients having adverse effects to antibiotics, prolonged antibiotics, increased length of stay. We know that infections will result in increased length of stay. So that's the aspect, a fairly simple way of looking and saying, well, do we have an increased length of stay? Because that's a cost to the organisation, both in terms of actual real cost of longer length of stay, but also with emerging funding models where some funding models actually penalise organisations for preventable hospital-acquired complications. And then, of course, there's the reputational aspect. If you have a hospital that's known in the community as having a high rate of, for example, prosthetic infections with joint replacements, then the population's not going to like it.
All right. You've convinced the executive that it's something that they should be concerned about. How do you get the executive to focus in on a small number of priority issues for change? An organisation with 20 or 30 priority issues for change is never going to be able to focus or achieve that change. You need to narrow it down to just a few. How do you go about engaging with executive and getting them to prioritise this issue in their change management program?
I think the executive, made up of multidisciplines, are going to be interested in all of those aspects. They're going to be interested in the cost, they're going to be interested in the penalties, they're going to be interested in the reputation, and they're going to be interested, hopefully, most of all, they're going to be interested in the individual patient and the patient experience. So I think you have to make a coherent case for why this is a major priority. I think that the other aspect is once you've got buy-in from the executive, then you need to take responsibility to say, okay, Everyone in the hospital is not going to be part of this steering group. Everyone's going to need to be involved, but we need to have a steering group, and the executive need to know that that's going to happen. The other aspect, though, is that executive, I think, also want to see that this one thing will not take over the hospital. They recognise that there are all sorts of imperatives, as you've said, for work that needs to happen in a complex organisation like a large hospital.
Thanks, Peter. The next challenge, I guess, is to get individual accountability. How do you ensure that the nurses providing care to patients and the surgeons and the anaesthetists are aware of the issue and take it personally? It's so easy in a hospital environment to say, oh, it's their problem, not ours.
I think the first step to that has to be to engage with key stakeholders in each of those groups in your working party, if you like, in your group, because there are going to need to be changes as a result, and changes and change management requires involvement and it requires engagement. On the other hand, you need to show people that it's everyone's problem, and one of the ways of doing that is having individualised reporting, if you like, of the urinary tract infections by ward, by unit, even possibly by clinician. There's nothing like demonstrating to a clinician that the performance in their patients is not as good as with other patient groups. And clinicians are always trying to improve things, and nurses as well. So they need to have that individualised data fed back to them.
So what level would you be aiming for?
It depends on the extent of the problem. It's nice to say, well, we have a zero target. And we all know that in the real world, that is almost never achieved. It doesn't mean, though, that it shouldn't be what the target is. On the other hand, if it's very small numbers and the numbers are, for example, less than the best performing benchmark numbers, then you're never going to be able to really make a strong case. You can say all you like that for this individual patient it's a huge cost, huge burden, and that's one way you can tackle that. But otherwise, it doesn't reach the level of importance for an organisation or for a ward or for an individual where they're actually performing well when benchmarked against colleagues or benchmarked against equal systems.
I think in Australia we have a reasonable tolerance for urinary tract infections. I know I'm on a board, and one of the board members of that hospital comes from an international organisation who's alarmed at Australia's tolerance for infection rates, very, very different from her jurisdictional expectations. Urinary tract infections often multi-causation. There's the insertion of the catheter, the care of the catheter, the patient's hygiene in hospital, the removal of the catheter. These can often be initiated by different teams within your hospital. How do you get those various teams, particularly the emergency department, who's more likely to be inserting the catheters on trauma patients? The orthopedic patients may be different from the rehab specialists who care for the patients after the treatment of their trauma. How do you get all of those teams to stop blaming each other and take responsibility and initiate change?
They have to be involved, or key stakeholders from each of those groups have to be involved right from the start in your initial team that you get together. You need to have everyone from infectious disease people who are the experts through to the infection prevention control, through to the nursing, through to the anaesthetics, through to the surgeons, through to the emergency department. So you actually need to have a representative at least from each of those groups on your team. It's a large group of people, but you don't have a choice if you're not going to have involvement of the appropriate stakeholders right from the start. No one likes to have something dumped on them at a later stage in the development. Apart from anything else, often you miss things when you're planning. You need to have the careful planning, and you can only do that if you have people right through. One of the key aspects, though, I think should always be asked is whoever the senior stakeholder of the managing unit is, the orthopedic surgeon or whoever, or the neurosurgeon, does this patient need a catheter? If the patient's going to be, after a knee replacement, up and about within 2 or 3 hours of back to the ward, do they need a catheter? And so you then need to say, well, if some need a catheter, who? If most don't need a catheter, then don't put it in the first place, because we know that catheters are probably the highest risk factor for urinary tract infection.
Australia's developed a number of guidelines, and it's very easy and tempting to just take those guidelines and impose them on your organisation. As a senior medical administrator, can you share some tips about how you go about getting doctors to think about their results and take ownership? As you've mentioned, imposing solutions can often be disastrous.
Absolutely. We've all had experiences along the way where we've tried and fallen afoul of our colleagues by mishandling that situation. There's no doubt, as I said before, that the best way to engage with clinicians is via what's important to them. So you need to involve clinicians in deciding what you're going to collect and how you're going to feed back the information. An effective method of feeding information to clinicians, which one of my senior colleagues has mastered, I think, is using data for each individual specialist and the data for the specialist group as a whole, ignoring at this stage the external benchmarks, which you can also use, but using that individual data and providing the group with de-identified the overall data source and also a de-identified but assessed individual clinicians' data, so that the individual clinicians can see, well, there is variability, and then the person whose data it is can actually see where they sit regarding their colleagues. And I think that concept of providing data to clinicians, but particularly the concept of involving the clinicians in what data you're collecting at the start, is really the key. Having said that, there are some aspects of all guidelines which the clinicians, well, it's not my responsibility, that's someone else's responsibility. So that's fine, and that's a compliance aspect. You can monitor and measure each aspect of it. But the key thing at the end are those patient-based outcomes, and individual doctor versus the group data, I think, is a very effective way of making that case.
Peter, can you talk about using data to police performance versus using data to coach change?
If we're wanting to get behavioural change, then it's best to use data as a coaching tool. If you want to set yourself up as a policeman, you're not going to have a good engagement with your clinical staff. Having said that, if someone continually is out of step with the overall group in terms of performance and they're not prepared to be coached or changed, you do sometimes have to make the hard decision to say, that's it. And I think as an administrator, sometimes and hopefully very infrequently, you do have to make that call.
They're the hard conversations, but hopefully they're rare. Then looking at the clinical governance processes in your hospital, it's a little concerning that the scenario implies you didn't know there was a high urinary tract infection rate until you received your benchmark report. Is this surprising?
I could answer yes and no on that. It would be wonderful to always know your organisation's performance and to know over time. The trap with that is if you're looking at your own data, you may think you've got a good result and it hasn't got worse. Therefore, it doesn't flag as a red on the classic KPI indicator charges. The good aspect of this is it shows the value of benchmarking and it demonstrates others may be improving. You may have been left behind and you won't pick that up with the normal organisational based reports because they are not looking at changing the baseline. They say, oh, against our targets, that's fine. But the target may have changed in other places. So, yep, you'd like to know about it, but you may not have picked it up. And yes, it's a great opportunity.
So the next report comes out in 6 months' time. What are you hoping for and how are you going to react?
You're hoping that your performance will have improved and that everything will be wonderful and you can stand up and say haven't we made a great decision? Okay, if that happens, fantastic. Celebrate it, provide the feedback to everybody. On the other hand, you may have done a whole lot of things and you may not have seen any improvement. And if that's the case, you then have to sit back, get the team together, ask yourself what's happening, also to look to make sure that the changes you thought you'd implemented have actually occurred. So it may well be a case of auditing the process again to see exactly what you're doing.
Thank you, Peter. Some great tips for medical administrators in the challenging position of needing to change behaviour.
Thank you, David.
That was Dr Peter Lowthian speaking about the fraught issue of hospital-acquired infections. That brings us to the end of this episode of Safeguarding Healthcare. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.